The following talk is for learning purposes only. The views and opinions expressed are those of the presenters and do not necessarily reflect the official policy or position of the University of Utah Health or AirMed. The participants are not paid endorsers of any products that may be discussed. Listeners are encouraged to consult their own agency's policies and procedures, common sense, and best practice guidelines. And now an AirMed talk on accidental hypothermia by Cory Cox.
There we go. Okay, so we're going to talk about accidental hypothermia. We're not going to get into therapeutic hypothermias, just the things that we would go on for, say, environmental conditions. So out of hospital traumatic arrest, think to yourself, what is the survivability rate of this? I'm not going to do a poll or I don't need a chat, but just think to yourself, what is the survivability of out of hospital traumatic arrest? But then think about the pre-hospital hypothermic cardiac arrest, and what do you think the survivability of this is? So this one's pretty easy, right? We know that it's pretty difficult. I mean, it's almost 0%. Unless we are really close to a hospital, a lot of heroics can take place in a short amount of time, then most likely your patient isn't going to survive. However, given certain situations for a pre-hospital hypothermic patient that's in cardiac arrest, actually their survivability is quite high, especially given the hospital system that we work with. And we'll get more into this a little bit later about why it's so high. Now, think about your traumatic or your trauma patient that is allowed to become hypothermic. What do you think that their survival rate is going to be? Do you think if we allow our patients to become hypothermic, it will increase their survival, decrease their survival, or really have no impact? What do we do on our typical cardiac arrest? We do have therapeutic hypothermia, but in our trauma cases that we allow to get hypothermic, it actually increases their chance of death by 2.5 times. And so as we come up into this season, we need to really think outside of the box about how to keep our patients warm. So the universal definition for unintentional hypothermia is the unintentional core body temperature of less than 35 degrees Celsius when heat loss to the surrounding is greater than the heat generated. Kind of makes sense, right? And most of the time it's going to be an environmental factor. Somebody's out recreating in the backcountry, they fall through the ice. Maybe it's a homeless situation and they didn't seek appropriate shelter for the night. And then maybe it could also be patients with pre-existing medical conditions. Age extremes, so the elderly, the young, trauma patients, and then malnutrition, and of course intoxication. And I think under intoxication, we could also add things that we do to that patient as well, giving them certain medications, paralytics, or pain meds that would prevent our patients from potentially taking away their ability to shiver inside of the helicopter. So classifications, there's 3 classifications. Mild is 32 to 35 degrees. This is probably where some of us have been before, just getting cold, doing some of our recreating. Moderate hypothermia, 32 to 28 degrees. And we'll get into a little bit more of the classifications a little bit deeper into this topic. And then severe hypothermia is anything less than 28 degrees Celsius. And then as you start to the temperature is one thing, and it's going to be hard to get a temperature to be able to classify them, but really let your management be guided by their symptoms. What is your patient telling you? What are your signs and symptoms that you're seeing? So of course the gold standard is going to be getting a core temperature. For us, esophageal temperature probes, but that might not be feasible in all patients. So at least try to take some kind of temperature on the patient, oral, axillary, rectal, whatever you feel like you can get on your patient. But again, those are pretty inaccurate, especially the colder the patient gets. And so just rely on things like multiple status and how they're presenting to you. Their vital signs, how are they doing with their heart rate, their respiratory rate, and of course their EKG. And then have a high degree of suspicion for elderly, homeless patients and intoxication. But I also think that a high degree of suspicion should be warranted in our patients even transported during the summertime. You know, you think about it, we are wearing our flight suits that they don't breathe very well in the summertime. Let's say it's even 85 degrees. That's enough to definitely get most of us sweating. And so we get inside of the helicopter and we've made our patient mostly trauma naked. We feel pretty good, but yet our patients might not feel good. And especially if they're intubated, they receive paralytics, pain management, and we've taken away their ability to shiver. We actually could have the potential to transport quite a few patients in the summertime that are mildly hypothermic. Whereas the wintertime or in colder seasons, we're actively thinking about that process. And so we are wrapping them up, or, you know, en route to the ski resorts, we're breaking open our chemical blankets so that we can treat it. But it's not such an active process in the summertime. Okay, so mild hypothermia, 35 to 32 degrees. We want to watch our heart rate and trend that, and watch for increasing tachycardias, shivering, of course, nausea or ileus. So this is a really good reason why not to give our patients warm fluids to drink. While it might make them feel better, it could come back out and haunt us a little bit later. And this is a pretty typical presentation, I think, in the late spring, mid to late spring, as the ice starts to thaw. You get ice fishing folks out there breaking through the ice, and it takes a few minutes to get them rescued. For the most part, they'll do pretty good just on their own once we can get them out of the cold environment, and they'll start to warm up on their own. But there is a phenomenon called cold diuresis that could take place. And so essentially it's vasoconstriction that, well, actually it's vasodilation in the central core, but vasoconstriction in the peripheries. So all that blood is going into the central core of the body, and then you may have a decrease in ADH production. And so your kidneys are thinking you have this overabundance of fluid, and now you have to get rid of it. And so as the patient begins to warm up, now all of a sudden they're fluid depleted, and you might get a hypotensive patient. So extended period of observation for these patients is definitely warranted. Just because they are now warm, we still need to continue to observe them. But also, again, on that exam, what is our patient showing us? Are they slow to respond to stimuli? What's their heart rhythm doing? So they do need to be hooked up onto a cardiac monitor. Clumsiness, you know, are they ataxic, can't grab a pen and sign their name? Little things like that. So moderate hypothermia. And Jason, I can't see the chat, so if anybody's asking stuff, can you moderate that?
Will do, you bet.
Thanks, buddy. Moderate hypothermia, 32 to 28 degrees. This is definitely going to be a very obvious symptomatic patient. Now your heart rate's going to start to slow down. You could see some hypotension in these patients. Cardiac irritability could start to take place with them. And these are the patients where you want to move them around as gently as possible. But this is also where you can start to see the loss of shivering, the paradoxical undressing. So a neurological condition, the patient's skin is so cold that it's become numb, so they're not feeling it. They might think that they're actually warm. And now, because of their altered level of consciousness, they'll start to take off their clothes, which then, of course, will increase their chance of further hypothermia. And then coagulopathies with our trauma patients, that's certainly a thing that we want to watch for. Severe hypothermia. So now you've got a patient that's going to be essentially unresponsive. Definitely we'll see cardiac dysrhythmias, including asystole in these patients. Hypotension, obviously with asystole. This is also a patient where this is like, you know, you're not dead until you're warm and dead. You might get a phenomenon called pseudorigor mortis, where they're locked up. Don't let that be an indicator of death. Rigor mortis is actually a pretty difficult condition to diagnose. So treat these patients. I mean, going through this presentation, I read multiple case studies out of Europe and Canada where these patients received 6+ hours of CPR, adult patients that received 6+ hours of CPR to have full recovery. And we'll get into what some of those recoveries include, but always have a high index of suspicion with something else going on. So whether that be low blood sugars, so check a blood sugar on all your patients. Look for signs of shock. Maybe a patient had sepsis and went down and passed out and have been down on the floor for a couple days even. CVAs, hypothyroidism can mimic this, malnutrition. So just have a high index of suspicion for other things that are going on besides just what the temperature is. Okay, so management for our patients. The good part about this is as the cooling decreases, there's hypothermia sets in. It's actually pretty neuro and cardioprotective, and so that does buy us time. But our goal is to resuscitate a patient until their core body temperature is at least 32 degrees Celsius or greater before terminating our resuscitative efforts. And I'll get into a couple of other things where we might still call a patient dead, but really be aggressive on their treatment. And I would say be aggressive even if you were transporting a patient down from, say, Montana all the way to the university. That's going to be a long, hard transport to get this body temperature up to par if we ever had one of those transports. So basic management, get them out of the cold, potentially take their clothes off. We want IVs on our patients. One is none, two is one, right? Cardiac monitor. If their clothing is wet, obviously remove it. Do multiple surveys of their body. Look for additional signs of trauma. But I want to pose this question out to the group though. What if you were a first responder for an ice fishing person that went through the ice and had been there for quite some time, and search and rescue and first responders can't get on scene, and it's just you out in the backcountry? Would you remove the patient's clothing? And that's kind of a difficult thing to really consider. However, the really nice thing that we have with our aircraft is we do have those the silver cocoons, the body fluid things. So you could, just like a newborn baby that we learned in NRP, putting them in a sack, we could do the same thing with our patients, even if they have wet clothing, to reduce their amount of exposure. So just because their clothes are wet, consider other possibilities of why you would or would not remove the wet clothing. We definitely have our blanket wraps and our thermal packs as well that can go into the patient. When you are so active external rewarming, this is basically removing the patient from the cold environment with the goal of increasing their body temperature. So maybe it's warm blankets, air conditioner, or excuse me, turning the heater on in the aircraft, whatever the case is. This is pretty simple. It's kind of the thing that you would do anyways if you were going to treat yourself. So other techniques is chemical packs. If you're going to use the chemical packs, put them in around the chest or the core area, the groin, the axilla. Have your pilot turn the heat on in the air conditioner. Excuse me, sorry. Oops, went too far. I bumped the little wheel on my mouse. All right. Have the pilot turn on the heater in the aircraft as quickly as possible, trying to keep that as warm as possible. So if you are on scene, keeping your doors closed. If you're in an ambulance, making sure the doors are closed on the ambulance. If somebody needs to talk to the patient, have them come in and close the door, but be pretty serious about that. This is a simple technique to do, and the rate of body temperature warming is about 0.8 to 2.5 centigrade per hour. It's not very effective for warming up the patients, but the biggest thing is you're preventing further heat loss. The other thing that possibly you can do if you have this mechanism available to you is you could put their hands in warm water baths, but you just don't want to exceed 113 degrees Fahrenheit. Active external rewarming. So again, this is maybe a smaller hospital that we're going to. They can take their cooling machines. It's similar to that you would use for therapeutic hypothermia, but now you're just doing it in reverse. So you're wrapping around the legs and their arms and the trunk of their body and just running warm water through those blankets. And that has an effectiveness of 0.6 to 2.5 degrees per hour that you could warm up a patient. And the other key thing here, though, is some of these techniques are so effective that you actually don't want to warm them up too fast. So if you are finding that your patients are warming up a little bit out of control, slow it down so that way you're not getting cardiac irritability. Warm water baths are not routinely recommended unless you have like one of those steak cooker things, those sous vide or whatever they're called. The reason for that is you just can't actively control the water temperature as accurate as it needs to be. Okay, active external rewarming again, adverse effects. As you get the effect of after drop, so as you're starting to warm up the core of the body, hopefully the reason why you don't want to warm them up too fast is you want to slowly warm up the extremities, the top of the arms, the top of the legs, so that you're not flooding the body with all this cold blood coming in. Because initially you might find that your patients are actually getting a little bit worse before they're getting better. And as long as they're in like a mild hypothermic state, you can deal with that pretty easy. But the bad state is when they're in a severe hypothermic state. Then now you're throwing all this additional cold blood at vital organs, the heart, for example. Rewarming acidosis depends on how long the patient has been hypothermic. So now we're bringing all this cold, stagnant blood back into the body, and so we could get a bump in our lactic acids. That's something to consider. And then how about rewarming shock? Like I described earlier, the phenomenon where you get potentially cold weather diuresis. So now your patient is fluid depleted, and as you're warming them up, now you're finding that they're becoming hypotensive. So why not just throw them on a pressor? That might be easy enough to do. Well, the problem is now you're adding a vasoconstrictor and you are increasing your myocardial oxygen demand. And so pressors are contraindicated for these patients. If you are starting to see hypotension, fluid boluses would be considered in these patients. If you have no other choice to start a vasopressor, just consider the risk benefits for these patients. And then also have a really high index of suspicion and look for frostbite, because if you're giving vasopressors, now you're even decreasing the blood flow to their skin even further, and it could worsen the condition. So management for these patients, the simplest way, warm humidified oxygen. Obviously, we don't have a way to do that, but sending and receiving hospitals do. Well, what they're going to do is they're going to give this humidified oxygen at about 105, 110 degrees Fahrenheit. And if you think about how much surface area that is, it's actually quite a bit surface area. And so that you're able to bring the blood into contact with, and so you're running 6 liters of humidified oxygen through those lungs every minute, and it's not the most effective way to bring up the body temp, but it is just another tool in the toolbox for that. So you can bring up the body temperature on average 1.8 to 4.5 degrees Fahrenheit per hour.
Hey, Cory. Oh, you got it right here. That was the next question in the chat, was about blood. Using the warmer, fluid warmer.
Yes, absolutely.
So perfect.
So the thing about these is yes, it's going to make us feel good, and it will probably make the patient feel good. Truly, as long as we're not giving cold fluid, colder than the ambient temperature, really, this does not have much of an effect on the patient. We would have to give such large amounts of fluid, and also at temperatures that our fluid warmer doesn't generate. But what it's going to do, though, is prevent additional heat loss, and that's the most important part, is we're preventing additional heat loss. So if you are going to give fluids, make sure we put them on the fluid warmer. And then you can also give the blood through the fluid warmer as well. Remember, our blood is cooled, our blood and plasma is cooled, so that would, again, promote additional heat loss for our patients. But if you are giving IV fluid, don't microwave it, put it through the proper steps for this, through some kind of a blood warming system. Okay, ECMO is definitely by far the gold standard for these patients that are hypothermia, so less than 32 degrees, and you're seeing some arrhythmias on your cardiac monitor. Hypotensive, so less than 90, and then definitely ventricular arrhythmias, so VFib, VTAC, and including asystole. Those are all indicators for ECMO, and then definitely if your core temp is just less than 28. Or watch the case study online. There's some pretty interesting reports on YouTube where people are videoing this in the operating room, and they're watching the patients as they start to rewarm. ECMO, you can rewarm a patient very fast, all the way up to 10 degrees Celsius per hour. That's probably a little too fast. But one of the things that you really want to watch on these patients is watching their pupils. So there'll be huge dilated pupils, and you'll know that the effectiveness of your rewarming status as the pupils begin to become reactive and mid-range. And then also during this time, you'll start to see potential arrhythmias. And if that's the case, then treat it to American Heart Association guidelines. So if you need to defibrillate, go ahead and defibrillate, probably up to a maximum of 3 defibrillations, because the thing is the heart's not going to act normal until it gets warm. Epinephrine in these patients probably is not going to be effective just because of their cold body state. And so if you do give epi, prolong it out, and then as the body starts to warm up, it can metabolize it, because it's just not going to metabolize it, and it's just going to sit there until your patient's finally warm enough. But then the other thing with epi is it's also a vasoconstrictor as well. And so again, you're going to, it's going to be harder for the blood to move around. You're going to increase the myocardial oxygen demand. So you might want to even consider holding off on epinephrine for these patients as they begin to rewarm. So we can go on bypass. This is going to be done in the OR. It's probably not going to be done in the ER. And then we can also do dialysis on these patients to rewarm them as well. So yeah, like I said, you can rewarm their body, and you can rewarm it at a rate that you want it to rewarm. So that's what's nice about this. And like in Canada, they'll have ECMO centers greater than 6 hours away, but they'll just sit there and do CPR on these patients until they can get them to ECMO. And they're having about 50% survival rates using ECMO on these patients. So non-ECMO possibilities is we could do body cavity rewarming. So we could do bladder lavages. That's pretty easy to do. We're gonna give them just about 105 degree temperature saline solution into their bladder. The thing about this, though, is it's not very effective. Again, it's going to maybe prevent further heat loss, but think about the size of your bladder. It just does not have that much of a surface area to it. So it's just not that effective. The other things that we can do is gastric lavage, but again, not much body surface area that you're coming in contact with just the stomach. And then you can do a colonic lavage as well. Hopefully we're not doing those in the helicopter. Okay, so closed thoracic lavage. Yeah, I think we could get away with this one. Popping in a couple chest tubes. Essentially what this is you're gonna do 2 chest tubes on each side. You're gonna do one high, mid-clavicular line, and then you're gonna do one low. You're gonna infuse the fluid, say 105 degrees Fahrenheit, and then you're going to let it drain out the bottom one. And you can do these bilateral, so 4 chest tubes total if you don't have ECMO available to you. That's just one possibility. The thing about this, though, is you also have to watch out for cardiac irritability, bringing too warm a fluid to the heart too fast. So this isn't routinely used, but maybe in certain areas it is. So more non-ECMO, endovascular temperature control, so large veins going in the femoral veins, and then as the blood passes through it, it's going to rewarm it. 5 degrees Celsius is what you, per hour is what you can warm up the body with this. And these are done in the OR setting, by the way. Rare instances, so this would be something that you're going to go into a very rural situation, potentially a patient that hasn't been able to get out of the hospital for whatever reason, distance, availability of aircraft, who knows. But peritoneal lavage for these patients, and that can warm up the body 2 to 4 degrees Celsius per hour. And it's 20 mils per kilogram of typically NS, but you can use LR or dialysis solution. Let it sit for 20 minutes and then drain it, and then repeat. Open thoracic lavage. This is going to be a patient that's received a thoracotomy, and then they just start lavaging that way. 8 degrees Celsius, but again, this is going to be a pretty rare instance that this is going to take place. Okay, so here's things that's going to mimic death. Fixed and dilated pupils. We know we're going to get dilated pupils when we get very cold. So in that moderate phase, the 32 to 28 degree Celsius patient. So don't let the pupils be an indicator of death. Stiffness, the rigor mortis, again, don't let that be an indicator of death. Patients are just going to get cold and stiff anyways. And then respiratory arrest and asystole. So now we want to think about who is dead, though. I mean, patients die, right? So if somebody dies and then they get cold, so Farmer Joe has a heart attack and he goes down by his tractor and he's found 2 hours later in 30-degree weather, he's dead. How will we know that? You know, sometimes we won't. Or what if it's somebody hiking in the backcountry and their friend has a heart attack and dies, and they're sitting there doing CPR on them, and they get there and their body temperature is 30 degrees Celsius. Well, the thing is the death probably took place first and then they got cold. So think about the pre-existing events leading up to the hypothermia that could cause this. If their core temp is greater than 32 degrees and you've gone through your resuscitative efforts, then they're probably going to be dead. Another patient is if they're just flat out frozen solid. This could maybe be in some of our homeless populations or prolonged exposure in the forest, or some kind of a situation like that. If you can't do chest compressions because their chest is so rigid because it's frozen, then you can call a patient dead on those situations. And then we have the other stuff, trauma, drowning, and avalanche. On our trauma patients, if you can remove them from the cold environment, we know we're going to get coagulopathies, and we know that there's a 2.5 times greater event of death that takes place with these patients. and then attempt to warm the patient somehow. You know, put them in those silver bags if you can. Cold water drowning. So this is kind of an interesting topic. I actually love this topic. There's a gentleman. Here's his. Oh, you can't see it. Anyways, his name is Gordon Giesbeck. He's a professor of thermal physiology from the University of Manitoba, and he's got quite a few videos online. He's got a cold weather boot camp that's pretty fascinating to watch. But you need to differentiate submersion versus immersion. So if somebody falls through the ice and they don't come through, they don't pop back up, or you know, whatever the situation is, they fall off a boat and it's 50-degree water and they don't surface. Well, the thing is that person went in warm and they probably died from a hypoxic cardiac arrest. They're most likely going to be dead within 15 minutes. There's really not a lot of chance of survivability with that. However, immersion is a whole different thing. That's where somebody falls through the ice, their head stays above the water, they still have an intact airway, they can fight for their life for quite some time. You look at case reports from the Titanic, people were heard screaming in the water for greater than 2 hours. And we know how cold that water was. I mean, it was just bitter, bitter cold. So you go in and you slowly get cold. So Dr. Giesbeck talks about the 1-10-1 rule. And what that is if you were to fall into the ice, you have 1 minute to control your breathing. And this is called the cold shock response. And so you fall through the surface and you get that. Well, breathing really fast takes a lot of energy. So you need to control that within 1 minute of falling through the water. And then you have 10 minutes of useful, strong muscles to try to self-rescue. There's different techniques for that, but basically to pull yourself straight out of the water in ice is going to be fairly difficult unless you're conditioned. But you have 10 minutes to think about a self-rescue plan for yourself. And water will take your body heat away 25 times faster than what the same temperature is of air. So as much of your body that you can get out of the water, that's what you want to do. This is called the cold incapacitation state. This can set on between 5 and 10 minutes, but the 1-10-1 rule is just an easy way to remember this stuff. And if you can, like if you get to a patient and you want to get control of their mind first, talk to them, hey, you can do this, you can do this. And even if they can get their arms out and grab onto something, a log that's floating in the water, or hopefully just their arms on the ice, if it's pretty cold, their arms are going to freeze to that ice. And so even if they go unresponsive, their arms will be frozen to the ice and they'll maintain their airway. But then you have 1 hour until hypothermia sets in. So say you go on an ice rescue event and somebody has fallen through the water, or the ice into the water. They have about an hour before it's a true emergency. I mean, yeah, they're going to be cold. There's plenty of videos online of watching people be in the water for 15, 20, 30 minutes. And they get out and they look like hell, but really their body temperature isn't that bad. They're maybe down 1 degree Celsius, but they're not that sick. They're still in that mild hypothermia state. And so we can deal with those folks. It's not until they're in the water for that 1 and 2 hour point that they become a really serious emergency. So that's his 1-10-1 rule. Avalanche victims. Now this is a tricky thing. We certainly have dealt with this in our environment. Let's just take a snowmobiler or a skier or somebody that's snowshoeing or skiing, whatever, and they cause an avalanche. And we can get to them in a reasonable amount of time and dig them out. Most likely their body temp is going to be high because they've been active prior to this event. And they're going to have clothing on for the environment, we hope anyways. And so the thought is if they're in the snow for less than 35 minutes and they come out and they're in cardiac arrest, that's going to be a hypoxic cardiac arrest, and the likelihood of surviving that is going to be pretty low. However, greater than 35 minutes, now the patient's going to be able to start to become hypothermic. So if somehow they created an air pocket, and there's case reports of patients having an arm out that was able to exchange air that way, and then they finally go into cardiac arrest. Or there's another case where a patient was able to get behind a tree, and which created a large cavernous area, and so they had quite a bit of fresh oxygen. But then they were buried for such a great amount of time, then they finally went into a hypothermic cardiac arrest. Then those are the patients that we would want to transport to the hospital and consider ECMO on. So pretty tough decisions there. And one more thing, I'm going to just go back to the water thing on a case study. Little kids that maybe fall into a river where they have such small surface area, they can lose their temperature really fast. So this is kind of a caveat to maybe the submersion theory, is that if a little kid were to fall in that river and they have that continual flushing of cold water over their skin, they can become hypothermic really quick. So kids are a zinger to the submersion theory. So they would probably want to be transported even if they're in cardiac arrest. That's all I had. I didn't want to take a ton of time because I know that there was quite a full agenda. Does anybody have any questions for me?
Hey, Cory, so I'm going to throw something out there on the whole after drop. I think that you could potentially just ignore after drop as a phenomenon for two reasons. One, because I don't think therapeutically that it'll change anything you do for these patients. And the other is I'm not convinced that it's an actual thing. And that's because if you take a watermelon and you freeze it and you have a temperature probe in the center of it and you stick it in a convection oven and warm it up, the temperature in the center will still be continuing to decrease. And there is no circulation that is shunting that cold temperature to the core. It's just that the inside is still cooling, and that process hasn't been reversed yet. So how much it contributes from, cooler blood from the extremities, they vasodilate a little bit and that gets sent to the core. How much is the core still cooling just because you haven't effectively warmed it yet? But I really think that as a concept, I don't think it has much bearing on how we should treat hypothermia. Food for thought. See what
no, I agree with you completely. I mean, it's kind of like a wheel in motion. So as you're getting colder, it takes time to slow that wheel down, and then you got to go the other direction. So, who knows if it is coming from the arm or the extremities, but I agree with you completely.
Cory, thanks for a really nice presentation. I want to reinforce your comments about mild hypothermia and how important that is for trauma patients, even in the summertime. We get these guys that come in and the first thing that happens to them in the ED is they get completely uncovered and covered up a little bit, but not enough. I'll tell you, when these patients that are bleeding, even in July, they come to the operating room, their core temps are always 35 degrees or in colder if it's not hot outside. And a little bit of hypothermia really makes their coagulation worse. Like people, if their temperature is less than 35 degrees and we're doing mass transfusion on them in the OR, they just will not stop bleeding no matter what we do until we get their temperature above 35 degrees. So even in July, going the extra mile to keep these folks warm, it's just really, really important for the outcome of these major trauma patients.
All right, thank you for the comments.
Along that point, remember the triad of death, right? Cold, coagulopathy, and acidosis. So any of those things are going to worsen a trauma patient, and so outcome. So super, super important. And the other thing I would say too is of the various techniques that you were talking about, rewarming, variable effectiveness. Some are not effective at all. And one of those ones that I would put into that not effective is the peritoneal lavage, because it's so hard to get that fluid back out. Chest tubes are one thing, and that's pretty easy to get that fluid back out. But what ends up happening most of the time that people try warm fluid in a peritoneal lavage is the fluid goes in, it's really slow to come out, and then that fluid cools down, and now you just have cool fluid sitting in the abdominal cavity. So I really have a hard time recommending that technique ever. But I think the other lavage methods are more reasonable.